So hello and welcome to this episode of Neurology Video Journal Club. Today we'll be discussing rituximab therapy in the treatment of juvenile myasthenia gravis, the French experience, that was published in Neurology. I am Dr. Sarah Wright. I'm a pediatric neuromuscular doctor at Children's National Hospital in Washington, D.C., and I am joined today with my co-discussant, Dr. Henry Kaminski. Dr. Henry Kaminski, do you want to introduce yourself?
Yeah, I'm a neurologist right down the street from Children's National at George Washington University, and I've been involved in research with myasthenia gravis for the last 30 years. And I am not a pediatric neurologist like Dr. Wright, and so I'm very happy that she's here to actually put some meat on the bones of this paper. And I'm also the PI of the Rare Disease Network dedicated to myasthenia gravis. So
wonderful. Yeah, I look forward to discussing this paper. I think it has a lot to add in the world of juvenile myasthenia gravis. So we'll go to the first slide that we have, which is table number 2. So the purpose is calling this juvenile myasthenia gravis. Juvenile myasthenia gravis is children who are less than age 18 who are affected with both ocular or generalized myasthenia gravis. And so just a brief summary of this study. It's a retrospective multi-center study that assessed different lines of immunosuppressant treatment and clinical courses of patients with juvenile myasthenia gravis. And it was interesting because they looked actually at rituximab as a first-line treatment for juvenile myasthenia gravis, including acetylcholine receptor positive antibody myasthenia gravis. So we see here for juvenile myasthenia gravis, the way that they had looked at this through the retrospective chart review, they looked at 74 patients in total, and then they looked at the patient population with generalized myasthenia gravis, those that were not treated with immunosuppressive therapy, who actually only needed the first-line treatment, which is acetylcholinesterase inhibitors, and then those treated with immunosuppressive therapy, and then further subdivided that into those who received rituximab or did not receive rituximab, and then first line versus second line. So I think this is pretty interesting, and I'll refer to you, Dr. Kaminski, as Henry from here on out, because this is a little bit of a paradigm shift in the treatment of juvenile myasthenia gravis.
Absolutely. I do agree 100%. It's a paradigm shift. And just a few general words. I mean, we all know that myasthenia gravis is a rare disease. It's highly heterogeneous. We don't know when we have that patient come through the room, what is going to be the treatment that helps them. And I think this study just demonstrates how much more complicated juvenile myasthenia gravis is, right? They collected these patients over nearly a decade at many prominent sites across France. And so they only came up with 74 patients. And then you start looking at, well, there's the ocular patients, and they all got cholinesterase inhibitors, and they did fine. You start looking at the kind of immunosuppressive treatments they had, and there's just a little footnote in a table, and they're all over the place, right? There's mycophenolate, there's another B-cell depleting agent, there's obviously prednisone, some people got thymectomy, a little bit of randomness to this. And, just another piece about the population here is some of these children, kids, as I call them now, really did well with pretty minimal kind of therapies. And another large proportion were in the intensive care unit. And, that just makes it very challenging to decide on what to do. And just kind of jumping ahead, corticosteroids and immunosuppressives are hard enough to use in the adult population, but corticosteroids in kids, it must be so difficult. And I think that's where some of the insights from this paper come from, that rituximab likely is a very good option, given the limitations of the retrospective study. So
yeah, absolutely. And so I think we're a little bit fortunate, so to speak, in the realm of juvenile myasthenia gravis, that for many of those patients, especially the pre-pubertal onset, are going to be, potentially just purely ocular or may go into spontaneous remission. But as the authors point out, some of the older patients, like you're mentioning, got a slew of different immunosuppressant therapies and a very wide gamut of, minimal treatment to being in the ICU. And we do have the discussion with families that, corticosteroids, obviously, as you know, are the first line treatment. However, they are associated with significant both short and long-term side effects. And for the growing body, short stature and low bone health is really a big implication. And I think so far we've also been pretty limited in some of our quote corticosteroid immunomodulating drugs, because a lot of those we discussed with the parents, the potential side effects, including some of the black box warnings of potential malignancy for azathioprine down the road, and that's something that many families don't want to kind of go down that road with that potential treatment. And so we're really limited. And so oftentimes we kind of resort to using a little bit of a mixture, and it's not really standardized for each patient. So I think that this paper really kind of helps us. And as you were mentioning, unfortunately, as of now, although this will change, the newer monoclonal antibodies are not yet studied or approved in patients younger than age 18. So it's really important that we have some treatment options.
Yeah, absolutely. And just a word about those. Obviously, this study was not done during the course of the development of eculizumab and now FcRn inhibitors, and so we don't have those kind of considerations. So I would like to point out that rituximab, though, is depleting those B cells that are producing antibodies, and so these other newer agents just don't affect those. And so there is that advantage of treating with rituximab. And, it's true in these patients here, and, maybe we could probably go to the next slide on that, that there's a group that gets a course of rituximab and they do really well. And they look like they're in a fairly long-term remission. And I don't think there's enough data here to say there's a few people who were retreated. We don't know how long that is. And so, there's the potential of just a single treatment with rituximab, and the patients will continue to do well. And I've certainly seen that in adult muscle-specific kinase myasthenia, not so much the adult acetylcholine receptor antibody positive myasthenia.
Yes, yeah, and to that point, we know the benefit of using it in anti-MuSK myasthenia gravis, and I think the authors make a very good point that using rituximab potentially early on may have, a similar treatment pathway in depleting the plasmablasts that then go on to create these plasma cells long-term for acetylcholine receptor antibody positive myasthenia gravis. And so I think that, especially for their first line rituximab group, although even the second line did, fairly well, that makes a good argument for using it early on in children, especially since it's so well tolerated. So the great thing is that really there's minimal side effects with infusions, and the rate of opportunistic infections is very low. And that's what this, same small cohort showed, that they didn't have any side effects, which I think is pretty remarkable. And I think one thing that was interesting to me, Henry, I was wondering if you can kind of postulate a little bit on this, is that there's so few patients, I know it's a small group to begin with, but there's so few patients who went on to get thymectomy after receiving rituximab first line.
So, well, as you know, the thymectomy has been well studied in the adult population, right? Mm-hmm. And there's no question for the adult, especially with early onset myasthenia and acetylcholine receptor antibodies, they really should get a thymectomy. And I think I think it's a very similar disease in kind of the teenage years as, the adult form. And so I would expect thymectomy to be beneficial. I mean, I'd like to hear what you have to say about the risks of thymectomy in, the 15-year-old, but it can be pretty safely done by an experienced surgeon, right? Which I know you do.
We do. For the acetylcholine receptor positive patients, we aim to do thymectomy approximately a year following diagnosis, as long as someone is, relatively stably controlled with their disease. So I think, though, for younger kids, when you get into the age range of, we've had some, 2, 3, 4, 5-year-olds, that's a very hard to try to postulate doing a thymectomy that young.
Absolutely. And, the issue you raised about the rituximab with thymectomy, the best answer is I don't know. And I think if you've treated somebody with rituximab and they're doing well, then there's absolutely no reason to put them through a thymectomy. I don't think there's,
Yeah.
there's a lot of biological reasons that I could say, oh, well, maybe it still would help, but that's all baloney, quite frankly.
Yeah.
Um, but about that early treatment, there was a new study. It was JAMA Neurology from a Swedish group that looked at early use of rituximab in adults. And it was a phase 3 study. You can kind of complain about some of the outcome measures, but it definitely, they reached their primary outcome measure, found a benefit in these early onset patients, as opposed to the phase 2 trial that Richard Nowak did in highly treatment resistant patients. And so I think that speaks to what you mentioned, that these CD20 positive cells are the pathogenic cells early on. And then as the disease progresses, probably long-lived non-CD20 expressing cells are the ones that are producing antibody, and they're probably locked up in the bone marrow where the Rituxan is just not going to attack those cells and it's not going to get at. So, I think there's lots of different pieces of information that are, leading to use of rituximab in, adult populations and juveniles now. And it's a rare disease. It's going to be hard to, or impossible to do a real randomized trial with this, right? I mean, we got to do our best with this. But the question I have for you, right? So this was done not in the COVID era primarily. And so at least in rheumatoid arthritis and MS, some of these B cell depleting agents can increase the risk of severe COVID infection. So, I mean, how do you counsel your patients about that? And, how much of a concern it is for you? Fortunately, I haven't had problems with any of my patients who are B cell depleting agents. And, sometimes the severity is such of the myasthenia that you just have to bite the bullet and do this, right?
No, absolutely. I think that, to your last point, if the patient needs treatment, really after discussing the risk and benefits, sometimes it's worth the risk. But we do counsel about potentially infections that they may encounter. We obviously do, pre-rituximab lab screening and then advise them to get their vaccines when they can before receiving the drug at an appropriate time frame. I think we've been lucky. We haven't had anyone have serious COVID infections with rituximab. We don't have a ton of children on rituximab because so far it's been pretty limited. We were really targeting mostly that anti-MuSK group, and then those patients who are acetylcholine receptor antibody positive who are refractory to other treatments. And I think also to that point, in the pediatric population, we know that COVID infections, thankfully, have not been as severe as some of, the older adults or middle-aged adults. So I don't know, but that would be a very interesting thing to look at. And hopefully, knock on wood, we don't have another COVID pandemic to have to answer that question.
Absolutely. We can all agree to that. So in table 4 here that we brought up, one thing that stands out to me in both these first line and second line treatment groups is the high percentage of intensive care treated patients, right? So, with these kind of retrospective studies, obviously there's the bias of how, the severity of these patients. But what I think points to this is that in general, the patients who are treated with rituximab early or, first or second, they were severe patients, right? So you're already biased to more severe patients, but it looks like they're doing pretty well, right? So I think that is another piece for, rituximab use in the juvenile population.
Yes, and like you were mentioning earlier, we don't know exactly when these patients were redosed with rituximab for those subset that was, but the fact that at their last visit follow-up, there's such a high percentage, especially of those patients who were treated first line with rituximab, were stable without any form of immunosuppression is remarkable. I mean, the quality of life, for these patients and the ability to avoid corticosteroids, can't be taken lightly. So obviously adults, have to go to work and have responsibilities as well. But, children having to be pulled out of school once a month for IVIG at home,
Absolutely.
And so to have a treatment that's potentially every 6 months is really remarkable.
Yeah, no, I agree 100%. And I don't think, I mean, we don't know the best dosing regimen, right? I mean, there used to be clearly, okay, dose 1 month and then 6 months later. I'm not sure that that's necessarily true. I certainly don't dose MuSK patients like that, right? I just wait for them to recur. And, there's some nice studies that Richard Nowak did that suggest that elevations in MuSK antibodies will predict an exacerbation. So maybe we'll have some sort of biomarker in the future for that. But yeah, I think, like you said, it kind of reboots the immune system in some way and can produce long-term remissions. Hopefully.
Hopefully. So I guess that brings us to a good point to talking about potentially what are some of the limitations of the study. And so I think we've already touched on this throughout our discussion. There's just such a variety of treatments, right? Even in the juvenile myasthenia gravis population, that's, at this point, still treatment limited.
Oh, absolutely. And I think, there can be just so much data placed in the paper. We don't know, where the other immunosuppressives started, how long ago. Perhaps they're already starting to develop their treatment effect when the rituximab is used. So absolutely. And then just their outcome measure is the post-intervention status, which is basically the doctor feels the patient is better or thinks the patient is better, depending on how you want to look at this. Well, so there's bias there. It's not I think it's the best they could have done for this kind of retrospective study. But, again, and this is a question for you in the, adult arena. There's a discrepancy between what the physician expert says and says, yep, you're doing good. And then at, 5 years of treatment, you're doing good. But then the patient says, by, other metrics, yeah, no, I'm not doing that well, and I'm still having problems, and all these adverse effects are getting to me. And so how much of that do you see in kids that you feel they're doing great, but their kind of lifestyle is still limited, and maybe that expands out beyond myasthenia. But yeah, what's your take on that?
It does. And I think that brings up a good point of where we should move forward. But to your point, adults have recall bias, right? Of how they're doing, their levels of fatigue, what's really implicating them on a day-to-day basis. We have that with kids, older kids, and then we also have their parents who have that kind of recall. So it's a double, 2 points to every story kind of thing. And so it does make it difficult. Really, how are they being functionally impacted on a day-to-day basis? Do they need a step up in therapy? Obviously, we have our exams, but I think that we're trying to move towards a place where we are starting to use more objective measures, as have been used in the realm of adult myasthenia gravis and obviously treatment trials for some time. There is actually a really nice outcome measure now that we can use in pediatric myasthenia that was developed by Dr. Partha Ghosh. It came out last year in Muscle and Nerve, that looked at outcome measures in juvenile myasthenia gravis and particularly the pediatric myasthenia quality of life 15. So I think we are moving forward to a place where we can actually start to use more outcome measures as a part of our post-intervention treatments.
Yeah, absolutely. And I think that goes to some of the take-home messages maybe we can kind of think through for the neurologists out there, just, more generally, that there often is the patients adapting to a certain level of weakness. And they may come in saying, yeah, I'm fine. And then we do an actual examination and they're clearly not fine. They might be a lot better than they were. And perhaps the parents say that too, because things got bad, but they're not doing well. So I think, I think that integration of the exam and what the patient and the parents are saying and trying to be as objective as possible to lead to ongoing treatment is clearly critical. And it seems like we both agree that rituximab should kind of come to the front of the mind earlier for many of our patients.
Yes. Yeah, I think as this paper alluded to, oftentimes we think of it in the more severe patients, right? Those patients who are either presenting with a generalized myasthenia gravis in crisis or with, significant bulbar symptoms, even though they might be acetylcholine receptor antibody positive and not MuSK. And those patients who have failed other treatments. But I think that we really should be shifting our focus when we have initial conversations with families for treatment options for myasthenia to include this upfront with the possibility of using, monthly or, a Q6 weekly IVIG for maintenance in our pediatric population, or, the potential of using corticosteroids.
Yeah. And the goal has to be getting them back to school, doing the things that they want to, socialize and such. It's the same way in an adult, right?
Exactly. Yeah. And hopefully on the path of remission, which is what we always hope for.
Yeah, absolutely. So I think we've kind of covered most of the things, right?
I think so too. I think that kind of concludes our discussion today for the article Rituximab in the pediatric juvenile myasthenia gravis population, the French experience, that was published in Neurology. So thank you all for listening.